presenter doesn't need introduction, but because we have a few fellows that might not know him, and also the fellowship candidates, just a few words. Dr. Vincent Baird is a wonderful partner and friend of Division of Nephrology. He's a professor of urology and works in the Division of Minimally Invasive Surgery over there. He is an expert in different aspects of urology, but the part that we work with him and we enjoy his education is the stone. He has a common stone clinic with Dr. Rucci, and has a lot of involvement in terms of patient care, research, and education. There is a lot to talk about him, but I want to leave him with enough time to educate us on the comprehensive care of kidney stones. Dr. Baird, thank you very much for accepting our invitation and being with us today.
Thank you so much, Dr. Zuri and Dr. Rucci. It's great to be with you all today. Once again, my name is Dr. Baird here in the UF Department of Urology. And what I'm going to talk about today is I discussed this with Dr. Rucci, and what I want to do is show you a urologist's perspective of stone disease, and to share that experience with you so that you can see what we're thinking. And over the years, Dr. Rucci and I worked together. We learn a lot from each other, and really the point is that. So I think that there's opportunity for us to learn a lot from each other. The learn objectives are here, right? And the key goals here are to understand the diagnostic tools used in diagnosing kidney stones, and then to understand surgical interventions and strategies for stone prevention. And then I'm going to talk a little bit about the multidisciplinary strategies that Dr. Rucci and I have as well. These are my disclosures. Neither of them pertain to this presentation. And so when we take a look at stone disease, in my mind, this is kind of how I break down the whole spectrum of stone disease, from diagnosis and treatment, evaluation, prevention, surveillance. And a very important thing to see in stone disease, right, is that stone disease is one of these disease states where you truly have a portion where surgical interventions are needed, and you truly have a portion where an understanding of medicine and medical intervention and prevention is also needed, right? So in order to really deliver great stone care, you need both of these elements. What I list here are the AUA guidelines, and these guidelines were made to essentially make practice standards for urologists. And as you can see, the surgical guidelines panel is a group of urologists, but what you'll also see is that the medical guidelines in the American Urology Association actually include urologists and nephrologists. They also have statistics experts and nutritional experts as well. Another thing that I want to tell you about my presentation today is that there's a then and there's a now. And I know that a lot of us have studied for a long time, and we know about some of the common standards and things that we do for stones. And what I really want to try to emphasize for you all are some of the new things that are happening in some of these areas of stone care in the outline that I showed you previous. One of these areas that we're going to talk about is artificial intelligence. And I know that we're all hearing about this a lot in the news. Sometimes it's a lot to digest because there's a lot of elements to it. But really the key in artificial intelligence in medicine is that there's three large parts. And I'm going to show some examples of how this works throughout the presentation. There's the acquisition of data from the various sources that we have. There is all sorts of analysis of data, and that's where we hear a lot about deep learning, machine learning, and things like that. And then there's turning these algorithms into clinical applications that we can use to help our patients. So that's kind of the big picture of what's going on in artificial intelligence. In endourology, in the world of stone disease, we use the word endourology because we treat a lot of stones with endoscopes, and so our field has come to be known by that name. In the past, we've focused a lot on imaging because imaging is very important to us, both radiologic imaging and endoscopic imaging. And a lot is done to try to predict procedural outcomes for different types of stones as well. And I just supplied some examples here for all these acronyms, right? We hear a lot about all these different types of algorithms and tools that are used in artificial intelligence to run these types of investigations. What are the key points from all of this? We do a lot of work at the current time with artificial intelligence, and we work with a lot of groups at UF. And there's a couple of key things that matter in artificial intelligence. The first one is data. And when you talk with artificial intelligence experts and engineers, they'll all tell you the same thing. What you really need is a lot of high quality data to be put in for the model to be good. And unless you have good data, the models really won't perform that well. The other key is that you need to integrate the different types of data, right? We have data on patients' vital signs and things like that, as well as serum analysis, imaging, pathology, right? The idea is just to combine all these things, and we'll show some examples of that as well, right? And then another key is using different AI techniques to process this data. One very important thing for artificial intelligence, which we are all very wary of, is we have to make sure that this data is properly protected, that there's proper privacy, and that we can run these models in an unbiased way. So let's talk a little bit about diagnosis. So as you all probably know, patients commonly, when they have these kidney stones, they'll come to the emergency room. A lot of them actually have small stones. And the reality is that a lot of small stones will pass. But when these patients come to the ER, what happens with them? If the suspicion is high for stones, if patients are young or if they're pregnant, they'll usually get an ultrasound first. Otherwise, the standard in this scenario, if the suspicion is high, is to do what's called a non-contrast stone protocol CT scan. And what happens is that if you have a BMI less than 30, you can actually get a low dose scan where actually the radiation dose in these scans is quite low. Versus if you have higher BMI, you'll have to get a standard CT scan because the largest reason is that the penetration of the CT scan in the pelvis is limited with higher BMI patients. Another very important thing for us in urology is the type of imaging. And we all know a lot about plain X-rays, ultrasounds, MRIs, and CT scans. And really, to sum everything up, it's clear that the CT scan is the gold standard. It's sensitive and highly specific for stones. I think some of the things that surprise folks is that you can see that the MRI actually is not very sensitive for stones. And we actually, this is not a test that we use for stones. Ultrasounds are mainly good for hydronephrosis. In terms of estimating stone size, I know that Dr. Rucci and I, we see a lot of these patients in our stone clinic, and ultrasounds are good for determining whether there's hydronephrosis or not. But in terms of densities within the kidney, it's limited. And part of the issue is that many recurrent stone formers, they end up with a lot of Randall's plaques and parenchymal calcifications. And then these densities can become confused with stones. And sometimes the radiologists will just determine any density as stone. But we know the reality is much more complex than that. So ultrasound is a great surveillance test where we can track patients for any changes, especially for hydronephrosis. When very specific questions need to be answered, CT is the way to go. This is just another summary of these imaging studies. What's different in this summary is you can see that they average together a bunch of different studies, and that's why you see just one number given for the sensitivity and specificity. I think people feel that the ultrasound sensitivity has improved a bit over the years with some refinements in ultrasound technology. And as you can see, the low dose CT, the radiation exposure in millisieverts is really not so bad. And this is why this has become the procedure of choice. A very important thing about CT scanners, as you probably all know as well, CT scanners yield a lot of information. They yield much more information than just the size and location of the stones. We can actually use the Hounsfield unit attenuation values to get an idea of what types of stones the stones may be, right? And the reason why I mentioned this, right, when we're thinking now about artificial intelligence and the way we combine data, right, this would be the kind of data point that you would want to include in a larger model, right, to see what stones are made of. Here, this study was done at Duke, and you can see how the stones are plotted out. You can see on the y-axis there is the attenuation value on the left, and you can see the uric acid stones at the low attenuation value. Then after them comes in cysteine, then struvite, then higher up you see the calcium-based stones, and then on top there near the top you see the ever-dreaded brushite stones. The problem with this is that even though it's good, you can kind of tell already there's some overlap. So this information is good, but it's not good enough alone. It has to be combined with other information to become more useful. So now we're going to talk a little bit more about what's happening with imaging today. So, just to kind of go back a bit, really, where did AI come from? AI came from something called data science. And maybe a lot of folks have already heard of that, right? Data science has actually been around for 20 or 30 years. And in data science, right, you're studying data and you're extracting meaning from it. What the difference is in machine learning and artificial intelligence is that you're utilizing this data, but the algorithm evolves and keeps on looking for the best results. So it's actually changing in time. And this machine learning, of course, is a branch of artificial intelligence. Here's kind of like a more detailed graph or depiction, right, of how machine learning is broken down. And really, the two big differences in machine learning is whether you do supervised learning, where you assign names and identifications to items, and then your model interrogates these items from a validation and a test set, versus an unsupervised learning, where essentially you have data and you let the artificial intelligence interrogate the data for any patterns that it sees, and then you try to correlate those patterns with clinically meaningful patterns that we see in our patients. So here's an example, right? So just a few years ago, a big issue that comes up with stones, right, is that, there's millions and millions of these CT scans done, and your radiologists are looking for stones. Some of the stones in the kidneys are easier to see. The ones in the lower ureters and the pelvis are harder to see. And essentially, the idea, right, is to make an artificial intelligence algorithm that can interrogate CT imaging and find stones, right, can identify stones on its own. And here's a specific study that was done, right, where they took all these CT slices, and what they did was they used what's called a segmentation model, right? So they interrogate all these CT voxels to have a validation set where people name the stones, expert radiologists name the stones, and then they test that. They have a second set, which is a test set, and they see how well the algorithm can perform finding stones on its own, right? And essentially what they did here, this looks complex, but really what's happening here is that they're taking the axial images of the CT and then the coronal and sagittal images, and they're letting the algorithm try to detect stones in all three planes. And then it combines those planes to predict whether stones are truly present at any given location or not, right? So this type of multiple interrogation is used, and the idea, right, is that you will decrease the error rate, right? You'll increase the sensitivity and specificity, especially the specificity. And what was pretty impressive, and one of the early first rounds of doing this, the model was already around 90% accurate in just finding all these stones on its own, right? So it's not 100%, but it's at 90%. Another term you'll always hear used with artificial intelligence is this dice coefficient. And all this dice coefficient really means is that you have your validation set and your test set, and it's measuring how similar they are, right? That's to say, you create a validation set with a repertoire of images, and then you test it a second group of images, and it shows you how good the validation set is as a representation of all the possibilities that exist. And the closer that is to one, it means the better your validation set is, and it's more likely to predict with accuracy what's in the test set. So this 90% is pretty good. But I think an important point here to make, right, is that a very important thing to know about artificial intelligence, and I've spoken to a lot of artificial intelligence experts about this, they will be the first people to tell you that in medicine, they most certainly want physicians involved in all the steps of this. There's really no intention to remove physicians from this process because there's too many clinical nuances, and you need the physicians involved to essentially make sure that everything that's done is actually correct. But the idea here is to help improve the workflow of radiologists so that the algorithm can do some upfront work, and then the radiologist can check these images. Things you can see from these algorithms, you get increased accuracy, faster diagnosis. The idea here, like I was saying, is to create a faster or more automated workflow. And of course, these models, you keep on growing their experience from the CT images with stones, and it's going to continuously learn and become better and better at detecting the stones on the CT scans. So let's talk a little bit about surgical treatment, right? So when we see stones, usually the order of stone care, right, is to remove any stone that can be removed because one, they may be causing symptoms, two, they could be damaging the kidney, and three, it's very hard to prevent stone if stone-nitis is already present. So our goal is to first get rid of the stones. In terms of these patients coming to the ER, the first question, right, is who needs an intervention? And I think this study that I'm showing you here, this is a very nice study. It was done in Canada. It involved a large amount of patients. And when you look at the graph here on the right, they clearly show who's benefiting from being allowed to pass stones on their own and who needs intervention. And what this study has shown and what other new studies have shown is that if you have stones in the ureter and they're 7 millimeters or greater, especially if they're in the proximal or higher ureter, odds are pretty high those patients are going to need an intervention. So right away, you can select these patients who are probably better off for procedures and leave the other patients to more likely pass the stones on their own. In nephrology, you probably all hear a lot about these stone procedures, and I supplied all the acronyms here so you kind of know what these procedures are, right? This SWL is the shockwave lithotripsy. The URS or REARS is the retrograde uteroscopy, right, where a mini scope is fed through the urethra and the bladder and the ureter up to the kidney. And then the PCNL is the percutaneous procedure where we put tubes into the kidney and through the back. Some rare patients these days have very large stones or very irregular anatomy, and they might need a laparoscopic or a robotic stone procedure or an open stone procedure. But it's important to make the point that these are very rare. You really don't see much of this these days. And as you can see, I have a column here for residual fragments, right? This is kind of the core of what we're after with all these stones, is that we want to get all the stones out and not leave fragments. And you can see that as the procedures become more invasive and more robust, that the likelihood of leaving fragments behind goes down. Shockwave lithotripsy has been around for some time. This essentially is here you can see this is Dornier in Munich in Germany, where they developed the HM3. HM3 is human model 3, the first clinical lithotripter that was used. Out of interest, the University of Florida was one of the first of 5 places in the world to get one because UF has a long legacy with stone care. And this was used for a long time. Uh, Concerns about it, you would really have to choose patients well. The stones have to be rather small. They have to be soft enough to be broken by the shock waves. Certainly, there are complications and issues that can happen from this procedure, even though it's quite minimally invasive. On the top picture, you can see a bunch of stones that got broken up, but then they went down the ureter. You know, it's kind of like pouring gravel from a fish tank down through a funnel, right? They all got caught down there, and the Germans coined this term Steinstrasse, Stone Street. And then on the picture below, you see there's a perinephric hematoma there, which is a more concerning complication from this procedure. Um, what happened to shockwaves in times? Its popularity has gone down. Um, Two big reasons why. The first reason is a surgical one, that it really doesn't completely get rid of that many stones. So that I'll make it simple, right? The and the other concern is from the nephrology world, where studies have been done, and people were long concerned about the micro trauma caused by the shock waves, and whether this was causing some type of more significant kidney injury and hypertension, new onset hypertension. And there's actually a few studies have been done with this, looking at very large patient groups, and people certainly are concerned that this is the case. Um, I will let you know that when I go to stone meetings, most academic centers throughout the world, very few of them use shockwaves anymore. People are pretty concerned about the limited efficacy, and they're concerned about the possibility of renal damage. I think both in urology and in nephrology, I think in the last decade or more, right, there's been increased attention paid to, even milder forms of kidney injury and what they can do to patients' long-term renal function. And of course, this is very important for patients' long-term health. Um, the next type of procedure is ureteroscopy, and this is where a, a mini scope is fed through the urethra and bladder up that to the ureter. Here you can see the scope with a stone, and that's a laser on the lower left that breaks stones to pieces, and the right is a basket that takes pieces of stones, and you can pull them out. The important points about ureteroscopy is this is direct vision endoscopy, so its success rates are much higher than shockwave lithotripsy. Um, the other very important point about ureteroscopy is that ureteroscopy follows the natural pathway through the body. So you don't have to cut anything. The scope just follows back through the urinary tract. And what's very important about this is that even when patients are sick, they're anticoagulated, or you really need to keep operative risk as low as possible, almost no matter what size the stones are, this is the safest of all the stone procedures. And we use it a lot for that reason. And so here, right, so here, this is a patient who came to us. They were very sick, and they had a stent put in around 5 years ago. And the urologists where they were at were afraid to try to remove it because, as you can see, the stent got encrusted with stone. But there's a whole bunch of stones alongside the stent, and you see this is one of these basketing devices that's put in, and essentially the basket can go in. This actually, the scope is in the ureter alongside the stent, right? And then you can take these stones out, and we essentially can go in there one by one and remove these stones. Be mindful, right? This is in the ureter. That's the guide wire going in the ureter. There's the petrified stent that's still stuck there, and we actually have to get rid of all the stone first because the stent won't uncurl and it won't unravel until you remove all the stones. So we go and get all the stones out first. Over the years, like I was saying, in terms of these stone procedures, you can see that the population of shockwaves has gone down. The popularity of uteroscopy has gone up. The percutaneous procedures are for the larger stones, and these larger stones present at a pretty steady rate throughout the years, so that has been relatively stable. In terms of this percutaneous procedure, this is the more invasive of the procedures that we do. And essentially here, what we do, right, is that the patient essentially has a percutaneous nephrostomy or access into the kidney. And then in the lower right picture there, you can see that we feed guide wires in through these nephrostomy tubes and sheaths, and we dilate a track into the kidney, and then a scope goes in there to treat these stones. Uh, as I said, this procedure is more invasive, but when stones are very large, sometimes it's the only way to really get stones out other than open surgery. And of course, this percutaneous procedure is still much better than performing an open surgery. The biggest risk, of course, is blood transfusion. I think in experienced hands, this transfusion rate is down near 2 to 4%. At UF, I think our experience with transfusion is maybe 1 to 2%. It's very low. So, like with experience and precision, this risk goes down substantially. A very important thing that's helped all these stone surgeries, there are new devices called suction sheets. And anyone who's seen a stone surgery, when you see the stones and you see the urologist tediously trying to break them and get them out, the first thing almost everyone says is they say, wow, it'd be great if you could just get some vacuum in there and just suck them all out, right? But it's not so easy, right? Because these access sheets are very narrow, right? And the suction column, it's very hard to generate suction strength through these suction columns. But this has been improved throughout the years with adjustable suction on these sheaths. And here, you can see, here's a suction sheath, and you'll see, here's a patient, right, with a percutaneous sheath in. There's very large stone that you can see with a bunch of smaller stones. You can see, amazingly, the sheath will just suck all the small stones out, right? It can just get them all out, which helps surgical efficiency a lot. Here is a scope going through a percutaneous sheath, and now we're using a laser, right, to break this big stone to pieces because it's too big to come out on its own, right? So, but what's nice is that the laser is actually breaking the stone, and the pieces are being sucked up straight out the sheath, right? So this is very efficient, and really the point here, right, is that this cuts down on operative time substantially, and these fragments don't remain inside the patient. So these sheaths have added a lot to the success of these procedures. I'm going to show you another device here. This is called a multifunctional lithotripter. And what this device can do is that it breaks up stone and it sucks them out. Actually, there's an ultrasonic rim at the end of that, a circular rim. And then the central core is a suction shaft. And actually what you can see here, right, is that some stones are not hard and mineralized. You see all that material, that's matrix material, but you can see that the suction device can just remove it all, and then you reach the mineralized part of the stone. So this has also been a great help. The only catch with this device is that you need a very big sheath to be able to use the device because, as you can probably see, it's a larger caliber type of device. What's new in lithotripsy? There's a term called burst wave lithotripsy, where essentially this is led by the University of Washington in Seattle, where essentially modified ultrasound can be used, one, to push stones around to try to get fragments to go down the ureter and pass, or you can turn up the energy and use the ultrasound to try to break stone to pieces. And you need minimal anesthesia for this. And at our national meetings, they've already shown videos where they can do some of this in the urology office. So this looks very promising. It's not for prime time yet, but many suspect that it's going to make its way into the treatment armamentarium. Let's talk a little bit about metabolic evaluation. Dr. Rucci and I see large amounts of stone formers. We see a large group of patients who already have a number of comorbidities. And really a very important point here, right, is that stone formers, for a lot of reasons, for both reasons of medical conditions and stone-specific reasons, they're at risk for CKD and loss of renal function, right? So this is a very important group to pursue care in and to try to employ as many preventive strategies as possible. Folks always ask, who should get a metabolic evaluation, a more intensive evaluation for stone prevention. And in urology, we list all these different types of reasons that you see here. And I know that you're all familiar with a lot of these reasons as well. Is interesting in urology, studies were done where people showed that first-time stone formers in patients with recurrent stones, they actually have a similar amount of urinary abnormalities seen on 24-hour urines. And for this reason, some folks recommend that really any stone former should get a metabolic evaluation. And I would further add to that point, if you see a young person and they have a stone, we all know that recurrence rates are very high within 5 and 10 years. Really, there's not much reason to wait, right? We really want to help these patients up front not get stones. And it's very reasonable to do metabolic evaluations, uh, especially because as a type of preventive care, metabolic evaluation in the grand scheme of things is not very expensive. And you have the opportunity to improve health outcomes and mitigate against costs substantially. So this is a very promising thing to do. Um, I just show this slide as an example of the guidelines that we have in urology for evaluating these patients, right? We're really trying to, I think in recent years, people are really trying to learn or gain insight into how patients perceive food products. I think we all know this is a big issue, right? We're all looking at the true nutritional quality of foods, more organic or natural foods versus processed foods. And this is an important item. Um, I 2 24-hour urines up front recommended, and there's actually national laboratories that run these tests, and they're done in a fairly standardized fashion at this point. What do we do in urology? As urologists, the most common thing we do is we want to check for stone analysis. We get a BMP, PTH for vitamin D to check the calcium axis, and we usually add uric acid if we're suspicious. And then we get the 24-hour urines, and then this is what we use for our prevention. Right, when you look at different types of things that you can find, Dr. Preminger is a kind of a pioneer in urologists and stone disease. He worked with all the basic science and nephrology folk at Texas Southwestern before he went to Duke. And I know a lot of nephrology folks know that research group as well. And they outline all these different conditions that can lead to stones and their prevalence at the time, both alone and combined. So you see there's a lot of different items that can be identified. In terms of stone type, I'm going to kind of stop again and go over some of the latest of what's involved with this. At the current time, we break up stones, take them out. The stones actually have to get sent out to a reference lab, which are almost like geology type labs where they look at these stones and then they put them in a variety of machines, infrared spectroscopes, X-ray diffraction, Fourier transform spectroscopy to determine what these stones are made of. Takes a long time. It's pretty costly. What are we doing? We're looking at how can we use computer vision from our endoscopes to try to determine what stones are made of, right? I have a slide here just to kind of stop again for a bit to go over an AI concept. So there's another huge AI concept called computer vision. And computer vision is huge, right? This is what's in the Tesla cars. I don't know if any of you have been in these Waymo taxis out west where you go into these driverless vehicles. We just had a stone meeting in Phoenix and we were driving around in a Waymo, and it's pretty crazy watching no one in the driver's seat and the steering wheel just moving on its own, driving you. And I can tell you, one night I actually took this, we went somewhere far away in Phoenix, and we came home late at night, and for a half hour, the Waymo just made its way around detours, streets under construction, and it made it back to the hotel flawlessly. And right, the point there, right, is that this is all from computer vision. And what happens in this computer vision is that you acquire data, you process it, the algorithm looks for features, and then it interprets these features. And so things it's doing, right, it's classifying things, it's localizing them, it can detect them, and even within types, it can detect differences in a similar kind of object. So there's two main ways you go. You can use bounding boxes, Here you put the bounding boxes on the cars, right? Or there's segmentation. The the bounding boxes are easier to do in order to process data. The segmentation is more tedious, but the segmentation's a pixel by pixel description, so it's a little bit more accurate. And essentially, what the segmentation can do as well is that it can do something called instance segmentation. That's to say that it not only can identify stones, but then it can identify different stone types within the stones, right? And so here we started with bounding boxes and we tried to see how accurate the algorithm was. It was okay. At best, it was only around maybe 60% accurate because the bounding boxes were not specific enough to look at features of the stones. Then we work with the UF engineers and we switched to a segmentation model. And in the segmentation model, we were amazed that we mostly had calcium oxalate stones. And right away, the segmentation model was already more than 90% accurate for the stones. And we were really excited to see that. You can see that it was actually very specific for the uric acid and struvite stones. The problem was is that we didn't have enough of those stones in the sample, right? So going back to what I said before, right? The validation set didn't have enough of these less common stones. So now I'm looking for more of these stones to add to our data set. Another problem with stones, right, is the quality of the imaging, right? So on the left, you can see we used to have glass or rod lens scopes, and you can see that the pictures were not that great. You kind of had to have a little bit of creativity to see things well in your mind, treat the stones. But then on the right, you can see that the digital scopes, it's like you just see stones in every last detail. You can even see if you look at the lower right, right, that's a thulium fiber laser was hitting that stone. And like, I can tell you that was a thulium fiber laser because I can even see the details of the laser marks that you can even see how it occurred. So the digital scopes are pretty impressive. Let's talk about prevention. Uh, there's a lot to do in the prevention world. Things start with fluids and diet. We all know that this is the the basis for stone prevention, and especially about determining whether foods may be oxalate rich in patients who have hyperoxaluria or calcium oxalate stones. Um, I think a really important point here, right, is that what really kind of made things hard for urologists in treating stones is that, as you all know, in nephrology, stone disease is really a lifelong disease, and it's rooted in the medical status of the patient. And you really have to understand these common medical conditions that are associated with the stones to be able to help these folks. And it is in this area that I've learned so much from Dr. Rucci about what we really need to do to try to prevent stones in these patients. And this is why you have to have this combined urology, nephrology type of evaluation of stone formers, because this is the only way you're going to get good results. And it's well known that even though there's only a handful of true multi-D urology, nephrology, multi-D clinics in the United States, that patients who are in them do very well. And I think I can definitely say that for our patient group as well. And you can see, right, when you get results from these multi-D clinics, you can and proactive and aggressive stone prevention strategies are instituted, you can decrease stone recurrence substantially. Pharmacologic agents. I know you all know a lot about the different types of thiazide diuretics and thiazide-like diuretics that are used to treat stones. And once again, there's many nuances here that are not appreciated by urologists that are appreciated by you all in nephrology. And this is a very important key in helping these patients avoid getting stones, about choosing the best agent for them, not only for stone prevention, but also because they have other medical conditions. What I think is very interesting in some of these studies as well, right, is that is my understanding that the original studies for stone prevention with thiazide diuretics involve patients receiving 50 milligrams of the medication, right? And so it's very important that, now that other agents are used, we really need good studies to see, how comparable and how effective these other doses and agents are. And I know that this is something that's ongoing. In terms of potassium citrate, right, we all know that this is a very common supplement that's given to stone patients. Citrate can raise urine pH, certainly help uric acid stone formers. It can also inhibit calcium-based stone crystallization, so it can be very effective in a number of scenarios. Um, and these here are some other pharmacologic therapies that are given. Really, for uric acid stone formers, we always start with potassium citrate. Urinary alkalization is the key, though some patients might need allopurinol as well. I think a huge plus we have had in the urology, nephrology, multi-D stone clinic is that for decades, cystine stone formers have notoriously done very poorly. They need very dedicated care, and our clinic clearly provides that. Rupam, I can say this patient group has dramatically done well in our clinic, and we have many very happy patients because of that, and that's just been a great benefit from our clinic. I think a big issue with potassium citrate, you all may know if you prescribe it, that sometimes it's very hard to get, and costs can vary a lot. So it's important to understand the different formulations that exist and ways that you can get this medication for your patient. Be mindful, right, that for patients it's very difficult if their insurance won't cover potassium citrate, then they have to go on the market and try to find it, and sometimes they can receive prices that are very high. But now there's a lot of items out there that can help patients, like GoodRx and other online applications that help patients find this supplement for a much more reasonable price. In terms of milliequivalents of citrate and alkali, I think a very important distinction here, right, is that what we really want to talk about is the alkali load, right? Not just citrate itself, but the alkali load that the patients actually get. And this is an early study that showed why Crystal Light Lemonade became very well known for stone formers because of its alkali content. I know there's a lot on these tables here, but just so you all know, in the Journal of Endourology, they have published papers that include a lot of these new formulations that exist. A lot of competitors entered this market realizing that patients had a hard time getting potassium citrate. And what's nice is that they show you prices, they show you the amount of citrate, and they show you the amount of true alkali citrate that you get from them. Ones that we hear a lot about are the moonstone and the litholite, especially. I think, and I think Dr. Rucci would clearly agree with me, I think probably some better studies need to be done to clearly see if these agents are truly equivalent to potassium, the current formulation of potassium citrate, because we all know, right, there's many dietary nuances of a formulation and absorption, and a lot of things may affect this, but I think this all needs to be better proven. Because just something else to know in terms of a clinical application, there is a chatbot called EuroGPT. There is actually a stone support group. I think they go by the name, the worst pain that you can ever have, and it's a stone support group. And this EuroGPT, essentially, it's a curated chatbot where a bunch of stone folks and researchers actually curated good quality medical data for the chatbot, so it actually responds quite well to stone-based questions. Something good to know about EuroGPT. Surveillance. I'm just going to say a few brief words about surveillance. Essentially, when we get 24-hour urines, I know one thing that works great in our multi-D clinic is Dr. Rucci gets a lot of follow-up 24-hour urines to test how effective the interventions are and to see whether we need to change them. And this is really important to do, right? Because you see an issue, you institute a therapy, but you really want to make sure that what you're doing is actually working. And so these follow-up 24-hour urines are very important. I think the Michigan group did a study, and they showed, unfortunately, that even after an initial 24-hour urine testing, only around 10 or 15% of folks get follow-up tests. And right, and we all know, right, that stones are a lifelong disease. This is not something that's just going to end. And these patients, what really makes the difference in long-term outcomes for these patients is following them up. And this is a key important of the follow-up. We always, when the patients come to our clinic, um, we usually check Q6 months for the first 2 years. If there's no recurrence, then we'll go to a year. We usually get ultrasounds to spare people any radiation dose. If patients are symptomatic or ultrasounds become suspicious enough in any way, then we go ahead and get CT scans. Um, what do I think is in the future for stone prevention? You need the multi-D approach. You know, we're working hard at this at the University of Florida. I think, but more of this needs to be done. And I think we really need to look more at what are the highest yield interventions for patients. And another area is that you need a multi-D approach, not just urology and nephrology, but you also need basic science involved, because for the magnitude of stone disease that exists, not much is truly known about its etiology, and you need good characterization about the different types of stone disease that exist to be able to formulate better treatments for them. I want to leave you all with one last thought here. So when we perform endoscopy, right, we can see the inside of the kidney, right? And now we have these digital scopes. And so you can see the inside of the kidney really well. And what you see here are these papillae. And Dr. Lingemann, a stone pioneer at the University of Indiana, spent many years collecting data on these papillae. And he essentially devised a classification system for them, right? And for all the reasons that I was just describing, right? You can now see them well. It's a unique source of information, not like radiologic imaging. Certainly, they're different in different types of stone formers, and and there's many details about them. It's like an advanced form of a physical exam, and essentially, what his work group did was they identified these different types of disease states that exist, right? There's these Randall's plaques, these little white deposits. There's these Bellini duct plugs, like these yellow type of mineral deposits you see. There's pitting and craters, and then there's depression of the whole papillae where they lose contour. And essentially, they want to use this both for clinical purposes and for research purposes. And so they took pictures of all the papillae in a large group of stone formers, and they kind of collated this data, and they made this kind of scoring system. And you see here they gave points, right, for plugs, for pitting, loss of contour, and then for the amount of Randall's plaque that was present, right? So what they would do is, like here, like they would show you how Randall's plaque would work, right? You would see an exhibit A there, right? You see a small just those small plaques there, right? And it would be they see no plugs, no pitting. The contour is good, but there's Randall plaque, so it gets that 0A score. And then you can see kind of in a progressive fashion that the scores would progress based on that same way. So here's pitting, right? So you see papilla, right? These papilla have higher scores because you can clearly see that they're more damaged, right? They in terms of having these large pitted areas. Essentially, what we see sometimes is that we find a stone in the ureter, and then we go look in the kidney, and you can see that the stone had erupted out of one of these sites, right? And so you can kind of see how this all occurs. Just as a final note, I again want to thank Dr. Rucci and Dr. Gazzori for inviting me. I love talking about stones, everything about stones, and I love to collaborate with others all the time in terms of the things we do. I also want to mention that I know Abdel Ali, Dr. Ali is in the Department of Nephrology now, and he has a basic science lab. And Dr. Rucci and I, as I mentioned earlier, we're now working with him to improve on a molecular level the characterization of stone formers. And I think this is going to be a very promising way to go. We certainly have a great patient population to look into what the details are. Dr. Rucci and I are involved in a number of projects together. The current time, we're going to look at the impact of GLP-1 agonists on 24-hour urines and stone formers. For a long time, we investigate the long-term outcome of stone formers. And then one of the things we're doing with Dr. Ali is looking at the role of extracellular vesicles in stone patients. Dr. Gazuri, I especially want to thank you as well for inviting me to become part of your division. And I'm also very excited, as I mentioned before, to be involved in the gradient study where you and us in urology, those in cardiology, I know we can work together in a multidisciplinary way to bring new technologies and new things to improve patient care. So thank you so much for that. I'm happy to answer any questions anyone has. I know I went through and told you a whole bunch of stuff. If I had more time, I'd tell you even more, because I love talking about this stuff. And I'm more than happy to speak with anyone anytime about our interests and our projects and things we do. I can tell, I would tell those who are visiting UF, UF is a fantastic place. The camaraderie and the collegiality between our different departments and divisions is amazing. And this is the way that we're going to produce better care for patients in the future. And so it's a great and exciting group to be part of. But thanks so much, everybody. I really appreciate the opportunity to speak today.
Thank you so very much, Dr. Bird. That was, as always, a wonderful presentation, very informative, and at the same time, practical. I just have to say that, Dr. Bird, we are trying to sell people that point of care ultrasound as a new physical exam, but you took us to another level. You urologists, you have to put a tube in our ureter to do the physical exam and tell us about papillae to say. You were saying it's an advanced physical exam for us? Wow.
Yeah. Dr. Gazori, I think what's amazing there, right, is that, right, what we need to do as urologists and nephrologists, we need to better characterize stone formers and the true nature of the etiology of the different types of stones that they're getting, because that's what's going to direct like the next round of research to really develop better care models for them.
Absolutely. No, that was excellent. I actually took a few notes for myself. A lot of things that you told us, it was really interesting and was food for thought. I didn't know about the shock wave lithotripsy going down this fast. The diagram that you showed was quite impressive. I have to say that the fact that for the recurrent calcium oxalate stones, you were saying that even if there is no metabolic abnormality, give a try to hydrochlorothiazide and potassium citrate. A lot of practical aspects. I really appreciate you being here and just educating us on the urologic aspects of urinary stone disease.
Yeah, and Dr. Gazori, I'll tell you all as well, and maybe you've heard. I believe at Vanderbilt they are doing a trial for empiric thiazide therapy for stone formers, just empiric, and
Just to everyone.
and that'll be interesting to see as well. Yeah,
Absolutely. Perfect. So the floor is open to everyone if there are any questions for Dr. Baird. I see Dr. Ali's camera is open. I don't know if you have any questions.
Yeah, sure. I'd like to make a couple comments. So first, very informative, really beautiful presentation, Dr. Bird, as always. So thank you for that. I just have one quick question. Is it known whether citrate therapy is more effective in reducing calcium oxalate or calcium phosphate stones? Or is it equally as effective for both?
So this is a great question, right? So for calcium oxalate stones, they form in a little bit more of an acidic environment, right? And citrate in that environment, right, is you can directly inhibit calcium oxalate crystallization without the pH concern. And then your second part of the question is the dilemma that Dr. Rucci and I always talk about, right? You have these calcium phosphate stone formers, right? Calcium phosphate forms at higher pH, and potassium citrate raises the pH. And so you have these two mechanisms of inhibition between direct crystallization and manipulation of pH. So there's always been this concern about whether those patients with the calcium phosphate stones should actually get potassium citrate. But in Dr. Rucci she probably has more experience in this than I do for sure. And Rupam, what do you think of that group at the current time?
Yeah, thank you, Dr. Bird. That was amazing. Yeah, Dr. Ali, I think it is the dilemma because these patients, the calcium phosphate stones, for one, they are highly recurrent and they have low citrate, high urine pH. Oftentimes you give them thiazides and they get hypokalemic. So even though their bicarb looks okay, there is some role or there is some, when you look at the pathophysiology, it is possible that they have some kind of incomplete distal RTA. And in that case, again, there are no randomized controlled trial or even good studies. Just some case reports, one or two, maybe not much in the literature. But now we have started giving some potassium citrate to these patients and see how they do. And at least in our experience, these patients have done better than when they were doing when they had, when they were not on potassium citrate. So there is role, especially in metabolic stones where there is pure calcium phosphate, hydroxyapatite kind of stones. There is some role for that. When I see bruchite stones, mostly, we still focus on more of calcium reduction, thiazides, maximizing thiazides, low salt diet, and all of those kind of things. But yeah, and they have a great role in cysteine stones and uric acid stones. They're mainstay of therapy as well.
Well, thank you both for that answer.
And Rupam, what's very interesting, right, is that when you medically treat the cysteine stone formers, right, you want to raise the pH for potassium citrate, right, to make the urine more favorable for cysteine. And on the 24-hour urines, we can see the calcium phosphate supersaturation, right? And we also know the outcomes of those patients in terms of formation of say calcium phosphate stones or secondary stones. But even when we push the pH up pretty high, that doesn't seem to be happening.
Yeah, you are very right. That's not the personal practical experience that we have had for sure.
Perfect.
Yeah, we could do a study. If we could collect those stones, we can compare them. And I think osteopuntin would be one of the molecules, one of the proteins that we can look at to see if there's a difference between the two groups of two stone groups. So it'd be interesting. There's a lot of things that we can do if we had stones from those two groups of patients.
We should do this more often.
Yeah, wonderful.
Thank you so very much. If others have questions, please reach out to Dr. Baird directly. You know how to find him in the interest of time. Again, I thank you, Dr. Baird, for this wonderful presentation. Thanks, everyone, for being here. I hope everyone will have an excellent weekend.
Thank you so much.
Thank you so much, everybody. Have
Bye-bye.
a great day.
Thank you. Bye.
Bye. Thanks.